Symposium. And I wanted to give a big shout out to our speakers and mentors. Although our fellow symposium is 3 hours this evening, our committee, speakers, and mentors have been working on this agenda for our fellow symposium for over the past 8 months. So thank you again for taking time away from your practices and families to spend time on our fellow symposium today. Before we jump into our next round of presentations, we have one additional trivia question for you. So everyone, please go to the chat window and click on the link for the next question, which is the song Pancreas, which was played at the beginning of our fellow symposium and during our break. What Grammy Award winner wrote and sung this song? Good luck. Now I'd like to introduce our next round of moderators, Dr. John Lieb and Dr. John Gorelick. Thank you for moderating this next session.
Thank you, David, and thank you to everyone for joining us for this exciting symposium for the National Pancreas Foundation. We have our third session today. Now that we've heard about a lot of the key issues in pancreas and pancreas cancer and pancreatitis, we'll talk about how can we actually fund our ideas and how can we bring those ideas to fruition. So for our first speaker today, it's an honor to be able to introduce Dr. Darwin Conwell, who is the chair of medicine at the University of Kentucky School of Medicine. And Dr. Conwell has been a mentor and an exciting investigator in the pancreas world for the past 30 years. And he has added greatly to our pancreas knowledge. So let's hear from Dr. Conwell about advances in clinical trials in pancreatitis. Thank you all.
Okay, thank you all very much for allowing me to present here at the NPF Fellows Symposium. I'll be discussing advances in clinical trials in pancreatitis. As an outline, we'll talk about mechanistic underpinnings of pancreatic disease, discuss NIH consensus conferences, research gaps and opportunities in pancreatitis, give you a high-level executive summaries of acute and chronic pancreatitis, and link in mechanistic clinical trials and wrap things up. Throughout the talk, you will have references, which I would recommend that you collect and read for your knowledge. The natural history of acute pancreatitis leads to recurrent acute pancreatitis that can result in the progression of fibrosis and loss of function that is chronic pancreatitis. Seen here, modified from a prior publication, is recurrent bouts of pancreatitis that can lead to end organ damage such as diabetes and steatorrhea. A lot of times patients will require surgery, but RAP increases the risk of progression with a hazard ratio of 4.5. The risk of RAP is primarily influenced by etiology, and you can see here that alcohol by far outdistances most etiology. So alcohol-induced recurrent acute pancreatitis results in chronic pancreatitis more so than idiopathic, other, and biliary. Progression from AP to CP in population studies varies throughout the world. You can see here Germany 13%, Japan 26%, Denmark 32%, USA 12%. The SAPE hypothesis, the sentinel acute pancreatitis event hypothesis, outlines Ashner cell injury. The initial event, called the sentinel event, results in a pro-inflammatory response. Later, stellate cells are activated and there's a pro-fibrotic response. If you can remove the stimulus, such as abstinence from alcohol, a cholecystectomy, or getting lipid-lowering agents in patients that have hyperlipidemia, you have the possibility of the reversal or the lack of development of fibrosis and activation of stellate cells. But if you have recurrent stimuli, you end up with a stellate cell mediated peri-Ashner cell fibrosis. This is depicted here, where you have a quiescent pancreatic stellate cell with insults to injuries such as alcohol. You have a activated stellate cell with some other inflammatory infiltration. And you have recurrent bouts of pancreatitis. This results in fibrosis. This is felt to be primarily a TGF-beta mediated fibrosis, but other inflammatory cells are involved that and cytokines and chemokines when you go from a quiescent stellate cell to an activated stellate cell. The end result is fibrosis. And this is felt to be the underlying mechanism by which patients develop chronic pancreatitis from RAP. A new conceptual mechanistic model of chronic pancreatitis has been proposed by Bakelman and colleagues. This allows us to do research in a more organized, structured way. Patients at risk with susceptibility factors and have injury, such as AP to RAPs, or the SAPE and recurrent acute pancreatitis hypothesis is inserted. Patients will go on to develop early chronic pancreatitis, established chronic pancreatitis, where there's dysfunction of immune cells, Ashner cells, islet cells, metaplasia, end-stage chronic pancreatitis, where there's loss of function, exocrine insufficiency, and diabetes can result in a subset of patients can develop cancer. This is where we can develop biomarkers, and a lot of research is being done right now trying to make a diagnosis of early chronic pancreatitis so we can try to retard the progression of end-stage disease. Now let's review acute pancreatitis. I'm going to give you what I call an executive summary of this. I recommend you read this article from Gut from the Dutch group. Acute pancreatitis is either mild or severe. 85 to 9% of the cases are mild. These patients have what we call interstitial disease, where the parenchyma of the gland, the blood supply has been preserved. In a contrast CT, you'll see the aorta is bright, the pancreas is bright. And this gland is interstitial disease, and these patients usually do very, very well. They're in the hospital 3 to 4 days. A subset of patients get severe disease, and they have necrosis where the blood supply has been lost. So now you can see where the aorta is bright with the contrast, but the pancreas is dark. There's also air here. This person has infected necrosis, and these patients are the ones that can get into trouble and have a high mortality. Over time, this necrosis can become walled off. It's called walled off necrosis. And if it's symptomatic, we'll have to have surgical or radiology or endoscopic intervention. From an executive summary standpoint, for you to understand how we manage acute pancreatitis, Ringer's lactate is usually hydration fluid of choice. ERCP is recommended for those patients that have gallstone-induced pancreatitis and increase in LFTs. Prophylactic use of antibiotics or probiotics is not indicated. Cholecystectomy is recommended in those cases with mild biliary pancreatitis during the hospitalization or within 4 or 6 weeks after discharge. The step-up approach is used with endoscopic or surgical management for infected walled-off necrosis. Patients that have biliary sludge or microlithiasis in the gallbladder, which is the most common cause for recurrent acute pancreatitis, have to have a cholecystectomy, and an ultrasound is the best way of detecting this. We have to monitor and be careful, and especially in those patients that have necrosis, for endocrine and exocrine insufficiency. But interestingly enough, patients with interstitial disease can also have loss of endocrine and exocrine function, and this is a point of study. I want to show you this paper. Lactated Ringer solution reduces systemic inflammation compared with saline in patients with acute pancreatitis. This is a paper, a study that we did at the Brigham and Women's Hospital with Beach and Wu and colleagues and Peter Banks. The important thing about this study is that I want to talk about mechanisms, and when we do research, we have to understand mechanisms and why we do what we do. So this study looks at randomizing 137 patients. 40 of them were randomized to either a goal-directed or standard hydration, and half of those patients got lactated Ringers versus normal saline. And the bottom line that was found is that goal-directed therapy was no better than standard therapy, and goal-directed therapy was based on weight of the patient in terms of its dosing. Standard therapy was just as the house officers felt the patient should be hydrated. Lactated Ringers, though, statistically showed an improvement in the systemic inflammatory response syndrome, and also a drop in the CRP at 24 hours. So systemic inflammation is definitely improved in lactated Ringers. The question is, why does this happen? So what is the mechanism? So this is a paper from Fred Gorelick's group. Lactate reduces liver and pancreatic injury and toll-like receptor inflammasome-mediated inflammation via GPR81 mediated suppression of innate immunity. And this just shows as lactate increases, this increases the GPR81, ARR82, which blocks the NLRP3, which is the inflammasome, which has the net effect of decreasing the IL-1 beta secretion, which is inflammation, which is a cytokine, so it decreases inflammation. So that's the mechanism behind how lactate decreases inflammation in pancreatitis. It's important to note there have been multiple consensus conferences from the NIH. A lot of these have been done by Dana Andersen, who's really spearheaded these consensus conferences that have moved the field forward. This is one called Accelerating the Drug Delivery Pipeline for Acute and Chronic Pancreatitis. I'm not going to show you all of them, but this just gives you an example. The take-home points are patient selection is important for acute pancreatitis studies, and also the early prediction of severe acute pancreatitis would be important. I will say, I'm not showing you this here, but George Papachristou and colleagues have developed a 5-member cytokine panel that has a very high prediction for early for those patients going on to develop severe acute pancreatitis, and they have submitted an R01 proposal to the NIDDK. What are some of the patient-reported outcomes that they feel are important? Pain, quality of life, nutrition, progression, and surrogate biomarkers. Trials are needed for pain. Trials are needed for the natural history of severe acute pancreatitis. Over here are research gaps and opportunities that are known that need to be evaluated. The NIDDK has developed the T1-DAPC clinical centers, type 1 diabetes and acute pancreatitis consortium. These are the centers that are involved in this consortium, and this is really looking at diabetes that occurs after acute pancreatitis. We know that pancreatitis is very common. A recent meta-analysis showed a 23% incidence rate of diabetes following AP. Routine screening for diabetes is not recommended following an episode of AP. Underlying causes, including the role of beta cell autoimmunity and contributing factors to diabetes, remain poorly characterized. And so this group was put together. So a consortium was formed. The DREAM study was developed, and this study's primary objective is to determine the incidence and clinical characteristics of any type of diabetes after acute pancreatitis, and to determine the clinical and mechanistic risk factors that predict the development of diabetes, assessing beta cell function after AP, and determining whether an altered immune state after AP leads to increased risk for developing diabetes. And this is just a study schema which you can review at your leisure. After patients are enrolled, there's a 3-month metabolic visit to assess their glucose homeostasis, and there's follow-up. This shows you the longitudinal assessments, and this is a 3-month glucose testing, OGTT, MMTT, FSIGTT. A subset will get MRI scans. So we're going to look at MRI imaging as a predictor of diabetes or not. And obviously, the metabolic testing will help us in regard to who has diabetes and who does not. Moving on to chronic pancreatitis, we'll do an executive summary also. This is a consortium that was also put on, sponsored by Dana Andersen and colleagues at the NIDDK. I was fortunate enough to be one of the senior author on this one, and research gaps and opportunities were defined for chronic pancreatitis. I would recommend you read this recent paper by Vikesh Singh and Dheeraj Yadav. There's also a recent article that came out in the New England Journal from Suresh Chari and Santi Veggie on a review on chronic pancreatitis. I would read that article also. This article, I think, is very well written on the diagnosis and management of chronic pancreatitis. It'd be very good for you to review this one. And it goes over a nice diagnostic algorithm and a treatment and management algorithm and the approach. It also shows you endoscopic approaches and surgical drainage for patients with chronic pancreatitis. There are representative imaging studies for you to also look at. It's a very well written review article. From that conference, consensus conference, a consortium was formed. These are the centers in the consortium called the Study of Chronic Pancreatitis, Diabetes, and Pancreas Cancer. We call it the CPDPC. From that, there have been multiple initial publications defining some of the strategies. In regard to chronic pancreatitis, the PROCEED study has been developed, called the Prospective Evaluation of Chronic Pancreatitis for Epidemiologic and Translational Studies. Standard operating procedures have been developed for biospecimens, and standard reporting for imaging for CT, MRI, and MR cholangiopancreatography have been developed. The PROCEED study is really designed to establish a model of longitudinal research cohort of adults with CP to look at the risk of progression to suspected CP, to definite CP, and to look at new onset diabetes and exercise insufficiency. We also now have the framework for developing candidate biomarkers, testing biomarkers, and performing mechanistic studies. The biorepository is rich and will be shared with the medical community at large. I want to focus your attention on pain. That's really the elephant on the couch for chronic pancreatitis patients. It's very complex. There are intrapancreatic factors, neuropathic and nociceptive factors. There are spinal factors, dorsal root ganglia, spinal cord hypersensitivity issues, cerebral cortex, there's cortical reorganization, central sensitization, hyperalgesia, and allodynia. These are all complex levels of pain that can be at various intensities, causing the pain syndrome the patients with chronic pancreatitis patients have. This is a paper that Phil Hart put together, and there are no current therapies to delay or retard disease progression, but there are ongoing efforts to more fully understand the natural history of chronic pancreatitis and underlying mechanisms of disease. These studies are expected to provide insights that will transform our approach to disease management and provide increased hope to patients. So I think this is a nice segue into accelerating the drug delivery pipeline for acute and chronic pancreatitis. This is trials in chronic pancreatitis workshop. Take-home points: patient input in developing treatments is important. Outcomes, pain, progression. These are some outcomes that are definitely needed in drug studies for chronic pancreatitis. Trials on pain management, trials on natural history are definitely needed. Came from the consortium. I'm going to give you one example of a study. This is called the PAIR trial, and it's a phase 1/2 trial of indomethacin in chronic pancreatitis. So prostaglandin E2 is a mediator of inflammation and fibrosis. You can see here PGE2 being secreted from stellate cells, and it's involved in chronic inflammation and fibrosis. We found that PGE2 is elevated in minimal change pancreatitis. It is low in normal pancreas juice. It's also lower in chronic pancreatitis. It may be a marker actually of early chronic pancreatitis. So this study, designed by Mark Topaz and myself, indomethacin is going to be, which can decrease prostaglandin E2 production via its COX inhibitor mechanism, can be repurposed to lessen the severity of CP. So a prospective randomized trial with indomethacin or placebo is given to patients, and we're going to look at pancreas juice and saliva PGE2 levels in order to determine whether standard dose of indomethacin effectively suppresses pancreatic PGE2 production. We're going to be looking at pain and quality of life. If this works, a larger multi-center study will be done. This is simply the study schema. At baseline, biospecimens are collected, study questionnaires are done, patients undergo an upper endoscopy, and pancreas fluid is collected for PGE2 levels. The study drug is started on day 1. Study questionnaires are filled out. Study day 28, another endoscopy is done for collection of PGE2 after secretin stimulation. Other ancillary studies are done in the CBDPC, multiple ones looking at imaging, pain, quantitative sensory testing, a medication called lacosamide for painful chronic pancreatitis, and other studies are in the works. So to wrap up, pancreatitis, it's important to understand the sentinel acute pancreatitis event hypothesis that ties in the relationship between acute pancreatitis, recurrent acute pancreatitis, and chronic pancreatitis. The mechanistic chronic pancreatitis definition will help us in our research. Understand the pathophysiology is important in managing patients with pancreatitis. The molecular biology will help us with treatment and drug therapy. Research gaps and opportunities have been identified. The NIH consensus conferences have really helped clarify this. Observational and interventional studies designed around mechanistic underpinnings is very important. I've given you a couple examples. The inflammasome-mediated inflammation by the GPR81 receptor is acted upon by lactated ringers in acute pancreatitis. Stellate cell activation via the COX-2 PGE2 relationship we're hoping that indomethacin will be an agent that can be repurposed to suppress this. The NIDDK consortium studies have launched several protocols. The U01 T1 DAPC consortium in acute pancreatitis has launched a DREAM study. The U01 CPDPC chronic pancreatitis group has launched PROCEED and DETECT. Now, DETECT looks at a type of diabetes called type 3C diabetes that occurs in chronic pancreatitis, the patient undergoing pancreatic surgery. I would highly recommend you go to some of these upcoming events and you join some of the societies. The American Pancreatic Association, you should join the American Pancreatic Association. This is our key group for pancreatology. I recommend you do go to DDW. It's in San Diego, which is a beautiful, beautiful place to always visit. Pancreas Fest is coming up in July, along with CAPER, the Cooperative Alliance for Pancreas Education and Research. Join CAPER, young investigators are there, and you can collaborate and get involved in studies. There's an NIDDK workshop on clinical trials in pancreatitis in July. Dr. Andersen also has put another one of these together. So these are things you should take advantage of to enhance your knowledge in pancreatic disease and really get around thought leaders in the field. I am now at the University of Kentucky College of Medicine, now the professor and chair in the Department of Internal Medicine, and Jack M. Gill endowed chair in internal medicine. So I'm very happy to be here. And my wife and I are looking forward to this phase of our academic career here at the University of Kentucky and broadening their pancreatic reach in Kentucky. So thank you very much for your time. God bless. Thank you.
Thank you very much, Dr. Conwell, for that outstanding summary. We have a lot to look forward to in terms of the future for treating pancreatic disease. That's great. So at this time, I'll introduce David Bakelman from the National Pancreas Foundation. He's the Chief Executive Officer. And Mr. Bakelman has been at the forefront of many nonprofit organizations, including the United Way. And I'm happy to state, as a Floridian, that one of his original degrees was at Florida State. So without further ado, I'll turn things over to Mr. Bakelman on how to obtain help from the National Pancreas Foundation and getting your career started in the pancreas world. Thanks, Mr. Bakelman.
Thanks for the invitation to speak at the 2022 Fellow Symposium. The purpose of a Fellow Symposium is, again, to form lifelong relationships and commitments to pancreas disease for our fellows this year, and to match you up with nationally renowned and world-renowned mentors where you'll have lifelong relationships with them. Over the next 5 minutes, I'm going to spend some time just going over key NPF programs, and then towards the end, I'm going to talk about opportunities on how to stay involved and engaged with NPF. NPF is over 25 years old, and the mission of the National Pancreas Foundation is providing hope for those suffering from pancreatitis and pancreatic cancer through funding cutting-edge research, advocating for new and better therapies, and providing support and education for patients, caregivers, and healthcare professionals. What is the differentiation point of the National Pancreas Foundation compared to any other nonprofit in the United States? The biggest differentiation point is NPF truly is the only national organization that addresses all forms of pancreas disease and supports programs in both the patient and medical communities. We address and impact acute pancreatitis, chronic pancreatitis, pancreatic cancer, pediatric pancreatitis, and FCS. We're really proud of the fact that 93 cents of every dollar raised coming from pharmaceuticals, genetic testing companies, medical device companies, and donors throughout the United States, 93 cents of every dollar goes to patient programs and research. To put that into perspective, that 93 cents of every dollar going to our mission makes NPF one of the most efficient charities in the United States. NPF programs can continue to support the medical community, patients, family members, and caregivers throughout the United States. As I take you through the next few slides, you'll see the impact on patients, families, caregivers, and the medical community. One of our most impactful programs is a Centers of Excellence program. These are medical centers throughout the United States where we are co-branded with a medical institution, but more importantly, it gives our patients, families, and caregivers, they have the opportunity to go to the website and call our office and find out where the most impactful, based on metrics and outcomes, pancreatitis and pancreatic cancer programs are in the United States. We're growing this program really aggressively. A year ago, we had about 110 centers of excellence. And as you can see from the slide, we're currently at 145 centers of excellence. All of our centers are located on our website. And again, it's a great opportunity for our patients to look either in their local community or whether they have to fly across the country to get the best medical care possible. One of the most impressive programs that NPF offers, which has received over millions of hits on our website over the last 7 years since we launched the program, it's called the Animated Pancreas Patient Program. They're easy to understand, 4 to 5 minute videos, which address different educational tools that affect pancreas disease. There's videos for caregivers, an overview of what the pancreas does, different types of surgery, medicine compliance, and we're just about to launch a new animated pancreas patient project, a video based on nutrition. As you're all in now, a fellow symposium, this is the 16th year of our fellow symposium. We're building the attendance every year with fellows as well as mentors, and we're really happy that you're participating. And we think by the end of our virtual fellow symposium that you'll have relationships in place, as I alluded to earlier, that'll last your entire career, and also you'll be committed to the impact of NPF. We're about to launch our patient registry. It'll be launched in conjunction with DDW in San Diego the 3rd week in May. It's going to be the first patient registry of its kind in the country that deals with all types of pancreas diseases. We're working with a company called Seekster, which is a health data platform that's one of the most effective platforms in the entire country. It's going to be patient-driven. There's going to be health records available that you can share with family and caregivers, as well as different doctors. So be on the lookout for our NPF patient registry. It will be launched in May of 2022. Our research grants is really a great opportunity for our fellows, meaning you, to apply for seed money for grants on an annual basis. Since its inception a number of years ago, we've provided over 127 research grants totaling more than $4 million. Early stage investigators will use these $50,000 grants and for cutting edge research, but more importantly, they leverage NPF research grants with larger funding opportunities through NIH and other funding opportunities. So it's a great opportunity for fellows to get in the ground level of applying and receiving a $50,000 research grants. So you can work with Dr. Paul on an ongoing basis or look at our website to find out more information about our grants. We're really excited is one of our key initiatives that we started about a year ago was to look at health disparities and access to healthcare for the Black African American Initiative. We're working with Cranes and WebMD in a multimedia approach, the first that's going out externally in the next few weeks. It's called a DigiReach Guide. It's the Education and Awareness Initiative looking at decreasing the incidence of pancreatic cancer and pancreatitis in the Black African American community. After the DigiReach Guide is launched and made available throughout the country, we'll be working on a social media campaign, going to health fairs throughout the country, giving presentations at Black African American churches and key cities. So we really need your support with not only launching this, but hitting the aggressive metrics that we have as an organization. What's really exciting is this has been the vision, excuse me, of Rebecca's wish and the board of directors of MPF over the last 4 years to really address the needs of the pediatric pancreatitis community. They face a whole different components of being inflicted with pediatric pancreatitis, whether it's lagging in education, social, emotional maturity, just all different things, peer relationships. So we started out with a virtual camp about 6 months ago, and we're really excited. In July of this year, we are working with a Serious Fund Network, which was founded by actor Paul Newman. It's a series of camps located throughout the country and throughout the world. So we expect a minimum of 50 pediatric pancreatitis patients, children, to come to Camp Hope, which is being hosted in Flying Horse Farms in Ohio, and really have a week-long fun experience of what it's like to be a kid, still having medical issues, but living life just fuller. So you'll hear a lot about Camp Hope. We have volunteer opportunities, and as importantly, we plan expanding this to multiple cities every year starting in 2023. Now, my final slide is what I mentioned at the beginning of my presentation, getting involved with MPF. Since I've been on board for 2 years with MPF, I've noticed that fellows who started 15 years ago are not only committed still to MPF, but more importantly, actively engaged and used it as a network with their peers throughout the country. So there's a couple of ways you can get involved with MPF going forward. As I mentioned, you can apply for a research grant for up to $50,000 for groundbreaking research. And that process usually starts in November, December, January for a call for applications. And then we make awards going into April and May. You could review with a committee of your peers as we get Centers of Excellence applications coming in to review those on either monthly, every other month basis. We have a committee that rotates on a monthly basis with reviewing applications, but it's a pretty effective process where you get to review your peer medical centers and make sure they hit the criteria for becoming a Center of Excellence. You could become an NPF chapter medical director and work with a volunteer in your local community. Currently, we have approximately 25 chapters throughout the country. They're involved in working with you and your medical facilities on facilitating webinars and in-person education events, involved in lobbying on the national and local level, and help with grassroots fundraising. So we really like your involvement with working with our chapters as a medical director. We have one of the stipulations with starting a new chapter is you have to have a chapter chair and a medical director chair, so we would welcome your involvement. The last two items regarding involvement, we started a national fundraising initiative last year called Pancreas Bowl. It's a great team building event for your medical institution. NPF handles all the logistics. What you do is you work with an NPF staff member to find a bowling facility. We call them up, negotiate pricing, and then we set a date together in conjunction with you, and you recruit people from your medical facility, your medical center. It could be nurses, surgeons, patients, family givers. Our goal this year is to raise over $150,000 for patient programs and research. And finally, there's an opportunity to serve on various committees. Two that I'm mentioning in the Black African American Initiative and Camp Hope. On an annual basis, it's probably about 15 to 20 hours a year for each one of these initiatives. So it's our hope that you'll contact Sakko or myself and get involved on the committee. So with that in closure, again, I wanted to thank you for the opportunity to give you a quick overview of MPF, and more importantly, getting involved with this year's Fellow Symposium. As a side note, since this is our third year of not having an in-person Fellow Symposium, in 2023 it will be in San Diego. And although you're part of the virtual Fellow Symposium this year, you're welcome to apply and attend to the in-person Fellow Symposium in San Diego next year. So with that, thank you very much.
I'd like to thank Mr. Bakelman for really the wonderful service the NPF has provided for patients, alerting the public to the issues related to pancreatic diseases, and also the remarkable support they're providing for for education in pancreatic diseases. Thank you again. Our final speaker of this session is a friend of a number of years, and Dr. Andersen is currently the Director for Clinical Studies Programs in the Division of Digestive Disease and Nutrition at the NIH. And Dr. Andersen, for those who don't know him, is truly a physician scientist. I came to know Dr. Andersen when he was at Yale as a remarkably talented and well-informed pancreatic surgeon. He also did some of the pioneering studies on diabetes occurring in the context of pancreatitis, especially chronic pancreatitis. He's gone on from there to chair departments of surgery, and I think to the great fortune of our community, moved to the NIH, and their heads programs related to research in pancreatic disease, especially clinical research and innovative areas of research. So Dana, thank you for coming tonight, and I think there's going to be particular interest, and I also am interested to hear what you have to say about funding opportunities for early stage investigators. Thank you.
Thank you, Dr. Lieb and Dr. Gorelick, and thank the organizers of the symposium for the opportunity to spend a few minutes talking to you about NIDDK funding opportunities for early stage investigators. You and we both have a goal of your eventually achieving what's called an R01 grant to support your research interests. The R01 grant is really the holy grail of academic research endeavors. More importantly, it establishes you as an investigator, not only in the eyes of the NIH, but in the eyes of your institution, and it opens many doors for you. And we are committed to helping you achieve the goal of R01 funding. And there are a number of institutional grants, including T32 grants, as well as a number of individual grants that can help you get to that goal. And what I want to talk to you today about specifically are the K grants, or the K awards, because they're a very important step that leads to eventual funding at the R01 level for new investigators. Now, you may wonder where the acronym K comes from, or where the initial K comes from. Ruth Kirstein was a much revered investigator. She was a pathologist who worked at the NIH Clinical Center. She was in the Division of Biologic Standards. She was the director of the National Institute of General Medical Sciences. She was the acting director of the NIH. And Ruth was particularly devoted to the idea of developing career development awards for trainees and early stage investigators. And so the whole K Awards series is really named after Ruth and the work that she did to establish these career development awards. And there are a series of K Awards. The K01 is the Mentored Research Award that's usually given to PhDs. The K08 is the award that we give to MDs and MD PhDs. And then there's a variety of other K Awards that are used less frequently. Now, the K Award is important because, first of all, it provides you with salary support. And for our institute, that means $100,000 a year plus fringe benefits at the institution's rate. And a 75% effort is usually required for the K Award. And that can be modified in certain circumstances if the clinical work that you're doing is an integral part and required for the research that you're carrying out. But for most individuals, the 75% effort holds. The K Award also provides research support up to $25,000 for technical support, supplies, travel, animals, and so forth and so on. So over the course of the 5-year award, that's worth about $750,000 for the individual. Now, before you think about submitting a K application, you have to have a position at an institution that allows you to apply. And what that means is U.S. academic institutions are the only institutions that are eligible to sponsor you for the submission of a K award. It's important for you to pick an appropriate mentor. That doesn't necessarily mean the person who's doing the same clinical work that you're doing. In fact, the best mentor may be off in a basic science department somewhere, and it's appropriate for you to spend some time searching for that appropriate mentor for the project that you might be interested in. You have to have published at least 1 or 2 papers relevant to the field of investigation. You should have your own preliminary data that have been developed, either by you or in collaboration with your mentor. You have to look at the funding opportunity announcement on the NIDDK website regarding which of the K awards it is that you're eligible for and that you're applying for. And finally, you have to be a US citizen, a permanent resident, or have applied for permanent residency status. Now, there are a number of elements that are evaluated in a K application. It's not just the research plan, but rather you as the principal investigator are being evaluated. The plan for your career development is very important because that's, after all, that's the basis for the award. It's a career development award. Your mentor, the activities, the contributions of your mentor, their expertise, and then finally the environment. And we'll talk about some of these specifics. How do we evaluate you as the candidate? Well, we look at your letters of recommendation, your biographical sketch, your statement as to why you want to conduct this research. And the reviewers are really looking to see if you are likely to become an independent investigator and a leader in this proposed area of research. Now, the reviewers obviously look at the research plan. They want to know that there is progress leading towards independent, that there's specialized training if it's needed, grant writing workshops and so forth to help you achieve your eventual career goals. It's important to look at the research strategy. Is what you're trying to do consistent with your background, with the resources that you have available, and with the mentorship that is going to be applied? The significance of the research, the innovation of the research, and the approach to the research questions are all considered in the application. And finally, the mentor is being evaluated. Does this mentor have the appropriate expertise in the area of this research? Has this mentor received research funding? Has the mentor been productive? And most importantly, has the mentor provided mentorship for other trainees? And then finally, is your department and your institution prepared to provide the protected time, the space, the opportunities for collaboration when you achieve funding through the K award? Now, NIDDK has had as a policy to try to fund at least 1/3 of the K award applications. And this graph just shows the funding success rate of K awards over the last several years. And as you can see, for the Division of Digestive Diseases and Nutrition, that 1/3 of the applications have been funded. And we intend to continue that ratio. Now, we also know that the K award is an incredibly important stepping stone to the R01 grant. So, for example, in a survey that was conducted a couple of years ago, we found that 80% of the K awardees eventually applied for R01 funding. And of those that applied, 53% actually achieved R01 funding. So this is a very important stepping stone that leads to funding at the R01 level. And when we talk about early stage investigators, our definition of an early stage investigator is someone who is within 10 years of the last step of their training processes. So that might be fellowship, it might be research fellowships, But once you finish training and become a faculty member, at that point, the clock starts for your early stage investigator or ESI eligibility. And this becomes important down the road. So there are a number of ways that NIDDK supports early stage investigators, one of which is to support workshops that are available to K awardees and to new faculty to help them establish their own skills in writing grants and obtaining funding. And most importantly, when you apply for R01 funding as an early stage investigator, you get a bonus in terms of your eligibility for the pay line. What I mean by that is that NIDDK currently funds at what we call the 16th percentile. That means that the top 16% of all the grant applications usually are funded. And for the early stage investigator, we push that pay line up to the 25th percentile. So early stage investigators who score in the top 25th percentile of their grant applications can achieve funding. And so this just gives you an additional bonus, an additional help towards eventual R01 funding. Now, it's very important for you to talk to NIH program officers for a whole variety of reasons, not the least of which is we can help you answer the questions of whether your project is right for NIDDK. We're talking about pancreatic disease, and many of you are interested in pancreatic cancer. And the NCI is really the institute that funds most of the K awards that are primarily focused on pancreatic cancer work. In NIDDK, we're particularly interested in precancerous risk conditions like diabetes and chronic pancreatitis, acute pancreatitis, both the basic biology and the clinical translational studies that relate to those forms of pancreatic disease. You may wonder if your project is enough for a K award application or an R01 application, and we can certainly help you to answer those questions and suggest possible study sections for your R01 application. And we can also help you find money. That's the important thing. There are a variety of supplements that are available through NIDDK for trainees and fellows. And one of the most important funding opportunities that you should be aware of is the loan repayment program. At NIDDK, we have 6 different loan repayment programs that apply to individuals who are pursuing clinical research, from individuals from disadvantaged backgrounds, individuals who are performing research in pediatric diseases such as pediatric pancreatitis, etc. So there's a variety of different loan repayment programs that you may be eligible for. The loan repayment features provide up to $50,000 a year for 2 years towards the repayment of your educational loans. And the NIH pays the taxes on this directly to the IRS. Furthermore, you can recompete for these awards multiple times if you still have substantial educational debt. To be eligible for a loan repayment program, you have to be a US citizen or a permanent resident. You have to owe more than 20% of your yearly salary as a bona fide educational debt. You have to commit to performing 2 years of research with a 50% minimum effort required concurrent with the loan repayment program. But the important fact is NIH funding is not required for support of that research. In other words, you could be performing research with a departmental award or with an institutional grant or a foundation grant. All of those apply for loan repayment program eligibility. And then finally, it can either be a mentored research program or an independent research program. So that the eligibility criteria are very broad. Now, how do you get there? Well, you start by looking at your department and your institution because they may have grant opportunities, funding opportunities that you can apply for, and that will qualify you for loan repayment programs. There are granting opportunities through societies and foundations such as the NPF. And they also help not only in making you eligible, for example, the loan repayment program, but they also help you to develop grant writing skills so that when you finally get to the point of writing a K-08 application or an R01 application, you've been through the process of learning how to write successful grants, and this is very important. Finally, people say, well, what should I focus on? What are the areas that are important in doing research in pancreatic disease? And one of the ways that you can become aware of what the knowledge gaps are and the research opportunities is to simply look at the conference summary manuscripts that are published every November in the journal Pancreas. Each year we put on a workshop devoted to a specific topic. This one in 2019 was on precision medicine. We did one last year on pancreatic pain. And these conference summary reports really summarize what are the critical knowledge gaps, what are the critical research opportunities that are important to move the field forward. And so this is like looking at a recipe to say, this is the critical research area that needs to be explored. And it's a good way to understand how to invest your energy and your interest and your resources. We have another workshop coming up this July on clinical trials in pancreatitis. And this is important for people that are considering studies that involve trials of drugs or trials of interventions as they apply to recurrent acute pancreatitis and chronic pancreatitis in both adults and in children. So for more information about pancreatic research grants, Jose Serrano at the NIH is in charge of this portfolio. If you're interested in understanding more about the K-08 award program, David Saslowski is the individual in charge of this program. And if you're interested in the workshop coming up this July or anything else, you're welcome to contact me as well. The point is that we are here, we're available, we want to help you to achieve your goals. Thank you very much.
I'd like to thank Dr. Andersen. That was a marvelous, comprehensive review of the application for the young investigators, and I'm sure it will be very useful for everyone. I received a message. We're going to reduce the period of the Q&A to about 10 minutes from 15 because we're running a little late. And John and I would ask you to put your questions into the to the question and answer box, and for any of the three participants, maybe I could start one out, and to Dr. Conwell. Darwin, there's been evidence from several groups that opiates will worsen acute pancreatitis and maybe chronic pancreatitis. And I was wondering, how should we be treating the pain of acute pancreatitis? Do you know the answer to that?
Yeah, I don't know if we have a complete answer to that. I heard a very interesting presentation at the American College of Gastroenterology by Beach and Wu out at Kaiser, and actually giving non-opioids in acute pancreatitis, actually giving IV tramadol, IV toradol, non-opioids, and actually getting patients out of the hospital faster and not giving opioids, and actually able to feed those patients faster. So I think there's some things coming down that we're going to be able to give us non-opioid management for patients with acute pancreatitis. I think some of the things about sphincter of Oddi stimulation and those types of things are not really that's not really been borne out by the literature. But I do think there's non-opioid treatments that can be used.
Thank you. Question to Dr. Andersen. Do the review committees for K awards view a publication on the topic of a K-word by the applicant as mandatory?
No, it's not mandatory. What the review groups are looking for and looking at is the ability of the investigator as the primary author of another publication to articulate his thoughts, the purpose of what he's writing about, describe the results of whatever he's worked on, and then to explain what the implications of that are. In other words, the review groups are just looking for evidence that the investigator has some depth of understanding of how you go about approaching and performing and communicating research. It doesn't necessarily have to be on the topic of the K08. In fact, the K08 may be a novel idea to treat a significant problem, but not one that the investigator has been directly involved with before. Or the investigator may have been involved in other clinical studies that, like pancreatic disease, are tough to understand and tough to treat. So that would be considered to be relevant. So the short answer to the question is no. What the review groups are looking for is your ability to communicate what you've done and why you've done it.
Thank you. Thank you. That's important.
So Dr. Andersen, to follow up with that, the K Award is, I mean, it's just a fantastic program, and it's just helped so many careers for young scientists. But on the other hand, I think one of the weak points of it is that there is a gap in the funding, in the sense that you have that $100,000, but to match another clinical salary, the institution has to cough up some to boost the mentee as well. A local institution has to put that out, and I think in some institutions there's a resistance to take on too many K awardees. I don't know if you can comment on how institutions can help attract these K awardees, and how institutions can support their K awardees.
Well, this is an important issue, and one would hope or like to presume that you, the early stage investigator, that you have chosen to work at an institution which regards your academic interests highly and which plans to support you. But when the rubber meets the road, the question is, where's the money going to come from to support the difference between what the K Award can provide you for your 75% effort and what you'd be making as a full-time clinician or with heavy clinical responsibilities, generating all those RVUs for the sake of your division and your department. Well, there's a couple of approaches to this. There have been several societies now that have created what might be called companion grants or companion awards, where they supplement K awardees with an additional salary bonus, so that helps to reduce that discrepancy between the K award and what would be considered a rank equivalent clinical award in the institution. So there are societies and associations, both in medicine and in surgery, which provide these supplements to reduce that discrepancy. And you can apply for those supplemental awards. So that's a big help. And it's just an added step of how you can support this. The other trick, if you will, is to understand that the NIH thinks that the work week is 37.5 hours. And for a lot of people, what that means is that they find it acceptable to take on clinical responsibilities for a big chunk of their time, realizing that they can still say that 75% of 37.5 hours is how much they're devoting to research. Now, this is a little bit of gamesmanship, maybe semantics might be a better way of putting it, But the point of it is that lots of folks who receive KO8 awards discover that they can still meet that 75% effort of 37.5 hours a week and still find time to generate clinical RVUs for their division and their department. So, you know, what the NIH thinks is a normal work week and what you and I think is a normal work week are worlds apart. And so that can work to your benefit.
Dr. Conwell, a question, and this might end up being the final question for the session. I've noticed that the House staff is using pancreatic enzyme supplement with the first refeedings of our patients with pancreatitis and continuing them on pancreatic enzymes. What's the basis? Is there a basis for that practice? And has that been really studied in a systematic manner?
I don't think there's that's been studied in a systematic manner. I don't think there's a theoretical, hypothetical basis for that, and this is that the pancreas may be stunned, but I don't think there's any indication for using pancreatic enzymes, pancreatic enzyme replacement therapy early in acute pancreatitis in the recovery phase of acute pancreatitis. I understand why people may want to do that, but it's not necessary. You've not lost. There's a lot of pancreatic enzyme reserve, and you have to lose 90% of pancreas function for you to start thinking about pancreatic enzyme replacement therapy. So there's really no reason to do that. But I understand why people would want to, but there's no reason to do that.
Thank you very much. Okay. Okay, I think we have the, coming towards the end of the session, we have the final quiz question up. I have to be honest with you, I don't think I've gotten any of these right so far. Hopefully the last one will be an easy one. Okay, how many quarts or milliliters of pancreatic fluid is normally? I think I know. Well, I may come close on this one.
You got this one, Fred. This one you got.
Well, the problem with it, Darwin, is that I always remember your papers on chronic pancreatitis. So I know what it is in chronic pancreatitis. I don't know what's normal. David?
Thanks, Dr. Gorelick. So it's my role now to close us out for the evening for our fellow symposium and transition us into our breakout sessions. And as Elizabeth Taylor said to her seventh husband, this will be quick. So this will be quick. So I can't tell you or state enough from not only our speakers and our mentors, but also from our board of directors. Thank you to our fellows for attending our 16th annual fellow symposium. And I really encourage you to take advantage of the relationships that are participating in our fellow symposium, but as and more importantly, as part of our breakout sessions. I'd also like to recognize our national staff at NPF who are responsible for coordinating and executing and planning our fellow symposium, Sakpal Chan and Carrie Andersen. This would not happen without you, so thank you for your leadership. Don't forget to fill out the symposium survey to help us with next year's agenda. The link is also in the chat, and we appreciate you taking the time to share your thoughts. So please take advantage of that and help us to plan next year's session. Although Fred just gave a number 5 trivia question, the last survey question of the evening is, and again, the opportunity to win an Amazon gift certificate is, since its inception in 2006, how many fellows have attended NPF Fellow Symposium? Thank you. Now it is time for our breakout sessions. If you are attending breakout session number 1, you'll stay on this Zoom link. It is titled Pancreatic Cancer and is hosted by mentors Dr. Eileen O'Reilly, Dr. Suresh Chari, and Dr. Jen He. Please wait on this link and we will bring you up on the screen momentarily. Links to the other 2 breakouts can be found in the chat and include Pancreatitis with mentors Dr. Darwin Conwell, Dr. Chris Forsmark, and Dr. Fred Gorelick. In our third breakout session titled Pediatrics is with mentors Dr. Maisam Abul El Haja, Dr. Melina Belain, and Dr. Roberto Gugic. Again, I wanted to thank you all for attending our fellow symposium, and specifically for our fellows. Although you're attending our fellow symposium virtually this year, we really encourage you to apply for next year's fellow symposium in San Diego in 2023. So with that, I'm going to kindly ask you to transition into your breakout sessions, and thank you again.